Hello and welcome. My name is Dorcas Erskine and I work with the UNICEF GBV and emergencies team. This resource is available both as a podcast and a video short. This episode on taking a crisis call, what to say and how to say it, is part of a series on GBV case management in the context of COVID-19. For the full episode, please check out our website, www.gbvims.com. In this episode, we will focus on how to manage a live crisis call, or basically GBV case management over the phone. We will look at guiding principles for taking crisis calls, the profiles of the types of people who will call you, and the checklist of things you must have ready before you take a call. But for more in-depth tips on setting up a hotline in general, please see the episode Prerequisites to Shift to Remote Case Management. In this episode, we'll also look at how crisis GBV case management on the phone will differ from what you would usually do face-to-face with a survivor. So we'll look at the case management steps you'll have to change. And we'll also go through each step and have live role-play examples of calls, including when a survivor is at imminent risk of harm. And then finally, we'll look at how to safely end a call. So if you're ready, let's get started. So the first thing we need when we're thinking about hotline work is the guiding principles that underline it. To be honest, the guiding principles in hotline work are similar to those that guide your interactions when you do case management work face-to-face. You're essentially still trying to build trust and create a sense of safety with a survivor, although you're in a very time-pressured environment. But a key way in which trust is established is by using empathy statements, actively listening, reflecting back what you've heard to a survivor, and summarizing. These actions all help you to capture the emotions underlying what a survivor has experienced and helps them to feel understood. What does this mean in practice? Well, to actively listen means that you're truly listening to survivors. You're not trying to wait for your turn to talk, because if you do so, you sort of miss the emotions underlying what a survivor is trying to say to you. You will paraphrase and reflect back a lot. So restating the content you have heard and reflecting back what you think are the emotions behind what you've heard. So that you show the survivor that you're not only listening, but you're beginning to understand what they have experienced and how it's impacted them. Summarizing. This assures the survivor that you've understood the key elements of their story, and also helps to bring focus to the call so that you can focus on the next step of case management, wherever that may be in your call. And it helps you have like a progress towards eventual closure of the call. Another principle is to encourage a sense of self-determination. As with static face-to-face case management, on the phone, you're trying to do something similar. You're trying to give the survivor a sense of control and autonomy, even in highly restrictive circumstances. And lastly, remember, silence is okay, and it's a key part of active listening. Sometimes all that survivors want is someone to listen silently and be a witness to their pain. Try not to fill every moment of silence. So who will call you and what will they need? GBV survivors who may be in active danger, those who may not and are just seeking information, referrals, and support. And also, of course, your ongoing survivors that you've been supporting through face-to-face work before the pandemic. You also might get calls from relations or friends of survivors seeking advice, and third-party professionals who may be referring survivors for support. And what will they need? So sometimes when someone calls you, they may be in crisis, or they just might want emotional support to gain clarity that the experience is really a form of GBV, and to gain information regarding healthcare, legal procedures, recovery, and other referral options that may be available. This is why it's so important to make sure that your referral pathway is updated and ready. So what must you have ready to support survivors who may call you and other callers? Do you have access to a private space where you can take calls confidentially and not be overheard? Do you have access to a private phone, such as like a phone you only use that's given to you by your organization to work on remote case management? Do you have your updated referral pathways of services permitted to operate during the lockdown? Do you have any connections or access to the police or trusted community support if survivors are in imminent danger? The fact of the matter is, in some contexts, official security may be absent or lax, but it's important as part of your setup process for the hotline that you investigate other options, alternatives that there may be, including informal and trusted community security structures, or maybe even access to respected and influential community members who may be able to assist in an emergency. Do you have the necessary official permissions to aid movement of survivors and perhaps their dependents to safe shelter if you have that service available in your context and it's requested by a survivor? And also, it's important you have access to your supervisor for support and guidance, because hotline work can be very stressful. Please do see the episode Prerequisites to Shift to Remote Case Management for more in-depth advice and tips. Now we look at the differences between standard GBV case management and the kind of crisis case management you might be doing over the phone. As you see, the steps are very similar, but in this process, you will see that some of the steps are necessarily shortened and processes may appear to be out of the usual order. This is simply because a survivor may have a very limited amount of time they can speak to you, and or they may be calling for urgent, immediate support because they or others are at imminent risk of injury and harm. So establishing if a survivor is in immediate danger should be your first and constant priority when you're on the phone. Secondly, the severe restrictions on movement for both survivors and most services as a result of the pandemic controls also mean that you might have relatively few options in terms of referral. So a slimmed down crisis case management system, which really just focuses on safety, health, and emotional needs, may be all you can offer in a lot of contexts. The diagram shows how remote and case management standards and steps appear in this. You would also have noticed that the action planning and case follow-up processes in particular look much shorter and are replaced with a stronger emphasis on assessing immediate needs, doing enhanced safety planning, and implementing short referral actions. In the next slide, we'll look a little closer at these short case management steps. So to recap, introductions will be shorter. As with all case management, we're often concerned with introducing ourselves, our organization, and gaining informed consent. In a remote process, you will still do the same, but you'd have to do it in a much shorter period of time. Later, we'll look at some of the quick things you can say to welcome a survivor. And there's also a role play you can watch for some tips later. You also notice that we say that the assessment process should be less detailed. There'll be less services that you can refer to, and the focus, as always, should be on immediate needs, safety, and emotional support. You also see that there's very limited follow-up. Unlike face-to-face, We don't recommend keeping case notes and files of these calls unless you're continuing ongoing support to survivors from your face-to-face services. You'll just have to accept that you will have very limited opportunity for follow-up due to restrictions, which will narrow the services you can offer to a survivor, and maybe often continued interaction as a result. Let's look at the first stage, introducing yourself. In the opening first few minutes of a call, you should really aim to establish the safety of the location from which a survivor may be calling. Look to assess the level of current risk or danger the survivor may be in, and provide safety advice and assistance if you have these services available. So as with static case management, you have to warmly greet the survivor, be transparent about your services, confidentiality, and any limits to confidentiality. But do try to spend no more than 3 to 5 minutes in introductions. Establishing if they're in immediate danger, remember, should be your first priority. Do this by determining whether they are alone and if it's safe to talk. So your initial questions should help you determine whether a caller is in danger from another person or persons who may be close by. If the caller indicates they are in imminent danger from another person, addressing their safety should take precedence. So until privacy can be established, try and ask close-end questions that can be answered with a yes or no, in case an abusive person is within hearing distance. Actively engage with the caller to identify the source or sources of danger, the level of risk, and if they need assistance. It's important, again, to note that in a large number of contexts, GB services will not be able to provide emergency assistance or rely on phone, on police services, and the technology needed to track a survivor's location. This is often a feature of hotlines in more high-income countries that is not available in all contexts. So therefore, being able to provide short, practical tips to a survivor on keeping safe in case of imminent danger, such as exploring escape routes, being able to contact trusted networks, is a must. And in the longer term, ongoing advocacy and capacity building of criminal justice or community security actors in your context should be a key part of your overall GBV program. Also remember, survivors are generally best able to judge their own level of danger and have pre-existing solutions. So as we do in face-to-face case management, it's be able to brainstorm with survivors as to what these are. We will look at this closer in a little while. If the caller is not alone and you're concerned that they might be in danger, consider providing a code word or a short phrase for the caller to say if they would like for you to terminate the call and or if they need security assistance, if you have that available. With survivors that receive ongoing support and case management via the phone and have safety concerns at home, you should really do this process. Make sure you have a code so the survivor can signal to the hotline staff when the survivor thinks that their call is being monitored and it's unsafe to talk. As I said, we have a number of case role play scenarios that you can listen to and watch to help you think through some tips on how to do this. The next step is to look at assessing safety immediate concerns. So the assessment process, as we said, is much shorter. It really is 3 simple things. Listen. Listen as much as possible and do not try to cut off the survivor's story. Remember our active listening principles. Assess. You're really trying to assess the safety concerns, including accessible social networks they can access, even in confinement. They're trying to understand their state of mind and their immediate needs now. This means you have to validate their story, show compassion, and have your referral network ready so that you can share information and brainstorm options for their immediate needs. Remember, we will have very limited follow-up. Please don't document information on a form or in case notes if there really is no possibility of follow-up. The next stage is safety planning. Please do watch or listen to the episode on safety planning for a deeper dive in this component of remote case management. But the key things to remember is you have to remind the survivor that she knows the situation best. Empower her. Help her identify the safest room or space in her own. Or more importantly, identify rooms to avoid, like the kitchen or any other room that has weapons or weapons that can be used in a situation of life danger. Help her make a plan with and for her children if she has them, namely a code word or a sign indicating they should go to a safe place. Identify her support system and resources, especially under new restrictions. She may not be able to access her usual support system. So what is a new and possible entry point? Make sure she has a plan in case she decides to lead, and ensure she's fully weighs the risk and benefits of leaving. Remember, some of the most dangerous times for survivors, particularly those of IPV, is when they decide to leave a situation of abuse. Remind survivors to delete the call record from the phone. One of the risks with hotlines is that perpetrators, particularly in situations of intimate partner violence, may monitor survivors' phone use. The next stage is implementation and ending the call. It's important that you inform the survivor about referral options for her immediate concerns that you've just assessed. Please do remember to make referrals with consent. Provide information on resources that may be available, whether that might be material, economic support, other resources that the government has made available in your context, hotline numbers for other services, and contacts of providers in your context. Encourage her to stay in touch with you, to call again if at all possible. Remember to share key messages, reassuring messages such as that the survivor is not alone, that the abuse is not their fault, and continually affirm and validate the survivor's feelings. It's really important that in the last few minutes, you seek to stabilize the survivor so that she's not leaving your session in a more traumatized state. Remember, she's been alone in her situation and has reached out to you, and that would have been comforting. And now she has to re-enter a situation where she may feel unsafe. It's really important to focus her mind and to stabilize her. Some of the activities you could do could include encouraging her to plan for the rest of the day and encourage the survivor to take one step at a time to try and be in the present. Remember, remind the survivor to delete signs of the call from the phone. So now we're getting to the end of this episode, and I just want to remind you that self-care is not selfish. Working on a call and a hotline is really difficult. And we have an episode on remote supervision and staff care for a deeper dive in this component, as well as an episode on safety planning that we had just recently discussed. It's important that if you're a supervisor, that you really emphasize that staff and safety, staff care and safety are really important. The fact of the matter is that supporting survivors through a crisis line can be extremely successful. You may often feel helpless as there may be limited options to help a survivor, particularly at this time when many services are suspended because of the pandemic. If you're a caseworker, please remember that you can't save a survivor. Your role is to provide survivors with emotional support, to help them think through whatever safety options they may have, and connect survivors wherever possible to professionals who can assist them. As a case worker, you also have to realize that not everyone can migrate from face-to-face to remote case management. Only provide hotline support if you're willing, able, feel safe, and you can do so in a safe and ethical and confidential manner. It's important you have the right support from supervisors. And if you're a supervisor, please ensure you put in place practices to regularly check in on your staff and their well-being. Some little things you could do could include daily or regular contacts with caseworkers to discuss their well-being and their stressors, encouraging caseworkers to actively reach out for support, using staff care tools such as the self-care inventory, which is available in the interagency GBV case management guidelines, and establish staff support networks. For example, creating WhatsApp groups to monitor daily well-being of all staff. Remember, self-care is not selfish, and you can't help anyone if you're not feeling well yourself. Thank you so much for listening to us today. To find out more about the series on case management in the context of COVID-19, please check out our website. And as always, please be responsible with your data. You can learn more at www.gbvims.com. Take care of yourselves. Bye-bye.